So the first topic today we are going to start is basically PCOS. PCOS stands for polycystic uh, ovarian syndrome. So polycystic ovarian syndrome, you need to understand the etiology. It will help you a lot. So insulin, hirsutism, infertility, increased estrogen level, like obesity, high BMI. These all are the features of polycystic ovarian syndrome. So it can present in any form. So this etiology is written here. It can start from here, obesity. A female, which is basically obese, present with increased peripheral conversion to the estrogen, then increase estrogen level, which causes decreased FSH, increase LH excretions, and eventually insulin also will be presenting as an resistance of insulin will also cause decreased FSH level and LH, high LH level. So there is a lot of uworld scenarios that I have seen, and they show that there is an increased level of obesity. What is the cause behind the increased level of obesity? So what happened in the obesity? It is increasing the estrogen level. So the scenario eventually they're asking in that if the female coming with a high BMI, which hormone or what kind of changing she will present with. So you need to know a female that is coming with obesity. What happens is there's a peripheral conversion because there is a lot of fat and peripheral conversion. So there's a lot of estrogen level production in her body. So that's why the FSH level is low and LH level is high. So you need to know eventually this mechanism just for you word. I don't think so. They eventually ask about this thing in MCC, but still it's good if your concepts are clear. So what happened here then, if FSH is low and LH is high, and evolution oligomenorrhea, and then eventually leads to infertility. So infertility can also present with PCOS. So on the side there is this scenario here, and you can remember it. Eventually most of the people remember it by heart, so if you remember with this mnemonic, it's good as well. So hirsutism, hyperandrogenism, infertility, insulin resistance, acanthosis nigricans. So these are the features that will present with the PCOS. Then the diagnosis, what happened? This is the Rotterdam criteria. So 2 of the 3 required. What happens? Oligomenorrhea, irregular menses for 6 months, hyperandrogenism. What happens in hyperandrogenism may be present with a hirsutism, acne, free testosterone level. So here I want to mention what is the most important hormone that is high in PCOS. It's not FSH, it's not LH. People usually miss thought that this is FSH or LH. It is not FSH and LH. It is high testosterone level. You need to remember this is a very, very important scenario. And I have seen this MCQ, I have seen it in a couple of Q banks. So you need to know what important hormone is raised in PCOS. So it is very important. So free testosterone level is high. Then PCOS, obviously you will find on ultrasound there is a lot of cysts present. On the side, there is maybe you can confuse with the congenital adrenal hyperplasia, then Cushing syndrome, ovarian and adrenal neoplasm, hyperprolactinemia, and hyperparathyroidism. So there is a few features, hypothyroidism. So there are a few features that is separating them each eventually. So what is the features like in congenital adrenal hyperplasia? There is might be hypertension. In Cushing syndrome, she has like a typical features of Cushing syndrome, and eventually in the hypertension. But in PCOS, there is no hypertension. Adrenal neoplasm, obviously there is hypertension, hyperprolactinemia, headaches and everything, hypothyroidism, constipation, and all those thyroid features. So if you know those features, you can eventually say, yeah, this is PCOS and this is not the PCOS, okay? Then clinical features, obviously average age is basically 15 to 35. So she can present in 16, 17, 18. So you don't have to think that she's pre-puberty or she's like less than 18. So she cannot present with PCOS. She can, okay? In aldosterone, wait at least 1 to 2 years. If you remember the scenarios before 18, what kind of diseases present before 18, it will help you eventually in a lot of places to make the diagnosis. So it is very easy if you make a list what comes before 18 and what comes after, which diseases come before 18 and which diseases come after 18. It will help you a lot in the making of the diagnosis. That's how I remember, but it depends on you, how you want to remember it. In adolescents, wait at least 1 to 2 years to make the diagnosis that adolescence resembles PCOS. Then irregular uterine bleeding, hirsutism, infertility, obesity, virilization, darkening of the skin, insulin resistance, and family history of diabetes mellitus. eventually you have to do investigations for everything. If she's coming with the PCOS, what you cannot miss is you have to do fasting blood glucose level. You cannot miss, maybe she is having an underlying diabetes for so long and you are not even checking it. So BMI, BP, fasting lipid profile, goal is basically hyperandrogenism or chronic evolution. So you have to think of all of those things. Laboratory, you have to check prolactin, TSH, T4, 17 hydroxyprogesterone, LH is more than FSH. So if LH is 2 times more than FSH, this is basically PCOS. But if FSH is high, then it is basically, I think it's basically Turner syndrome. So there are few tips that I think it's mentioned in the uworld in some tables that I sent in the group. So you can see it from there how you can differentiate the three syndromes: congenital adrenal hyperplasia on the basis of these hormones, LH, FSH, congenital adrenal hyperplasia, Turner syndrome, and PCOS. You need to know which one is high in which one. I don't want to say it wrong, so you have to see it from there. Increased dihydroxy and androstenedione ion, and free testosterone, more sensitive. Since I already mentioned, testosterone is very, very, very sensitive, even more than LH and FSH. Then in the transvaginal and transabdominal ultrasound, polycystic ovaries are the strings of pearls. Then comes the insulin resistance. You have to rule out OGTT. By doing OGTT, you have to rule out diabetes mellitus. It's very important. If they say PCOS patient is coming and you have to rule out one thing, what is that? Diabetes mellitus. Consider a biopsy, obviously, for the long, rule out hyperplasia, rule out other causes of the abnormal bleeding. Then on the side, sign and symptoms of endocrine imbalance, menstrual disorders, amenorrhea, infertility. The most common is amenorrhea, and then comes infertility, hirsutism, obesity, glucose intolerance, and diabetes. Long-term health consequences: hyperlipidemia, diabetes mellitus, and endometrial hyperplasia, subfertility, obesity, and sleep apnea. So you have to remember it by yourself. Like, this is not something I can explain here. So you have to remember what are the health consequences that can present and what you have to rule out for sure, for sure, for sure. Then comes the treatment. What is the treatment? First thing first, always start from the lifestyle modification. If somebody is coming from something and she doesn't have a very high features, unless she is having something very high features like having amenorrhea for so long and now she wants the treatment, then you will obviously start from OCPs or something like that. But if she is coming with some high BMI, then first thing first, what is that? Lifestyle modification. Hormonal IUS. If that is not working and she's presenting also diabetes, then also metformin you can start, and a lot of menorrhagia, then tranexamic acid. Then the treatment depends on the type of the features she is presenting, a type of the symptoms she is presenting. You cannot write everything simplifyly. Like, let's suppose if in the scenario they said a woman coming to you with the PCOS and having amenorrhagia, you cannot start with the lifestyle modification. You have to start with the tranexamic acid. So all the treatment starts with the treatment starts with the symptoms. Infertility, what you give is letrozole, clomiphene citrate. What commonly used is basically clomiphene citrate and letrozole. There is another written hormonal menopausal gonadotropin, LHRH, FSH, metformin. So you can start anything. Metformin can be used in conjugation with the clomiphene citrate. So if you're writing clomiphene citrate, you have to mention that you are also going to start metformin. Then ovarian drilling, it is very life-threatening kind of, because if you are doing in a wrong or maybe any complication occurs, so it's rarely done. That's why. Then bromocriptine for hyperprolactinemia, and then hirsutism, Diane, yasmin, and mechanical removal of the hair, finasteride, flutamide, and spironolactone. It depends on what the patient choices. So you can do all of these. Mostly what is used is basically OCPs, because OCP you can use for the other features as well and also for the hirsutism. So you can take one medicine and use all for both of the benefits. Okay, then comes the gynecological infection. So you need to know the physiological discharge. I'm not reading it because this is something which is very common and I hope everyone knows about it. But this physiological discharge is very common, because if you know the physiological discharge, then you will be able to tell, yeah, this is physiological discharge and this is pathological. So you need to know the physiological from the pathological. That's why physiological is very important, which is basically clear, white, flocculent, and odorless. Now we will read, so these are the all diseases that are mentioned, like genital tract infection, candidiasis, trichomoniasis, gonorrhea, and chlamydia, salpingitis, genital tract infection, any douches, sprays, foreign bodies, vulvar and any endometrial neoplasia, toxic shock syndrome, Crohn's, collagen disease, and dermatologic, like lichen sclerosis, IUD, and OCPs. Vulvovaginitis, it's written here on the side here. Most common gynecological problems in prepubertal girl is non-specific vulvovaginitis, not yeast. So a lot of people think that the candidiasis is the most common. No, candidiasis is not common. Most common is vulvovaginitis in the prepubertal girls. So these are etiologies written here. Most of the common organism is basically group A streptococcus. Etiology is basically any lack of labial development, any unestrogen, pH level, obesity, poor hygiene, foreign bodies, bubble bath, and shampoos and anything that is basically used as a chemicals and stuff like that. Then also some skin diseases like lichen sclerosis. So you need to know what is lichen sclerosis and lichen planus. So those two things you need to know. Trauma, then accidental straddle injury, and sexual abuse. Infectious pinworms, candidiasis, streptococcus, staph aureus, shigella, STIs, polyps, tumor, vaginal complaints, and endocrine abnormalities, blood dyskaryosis, measles, anything can present with the prepubertal vulvovaginitis. Then infection, what are you going to do? You have to rule out STIs. So that's why you are going to do vaginal swab for the culture, and then pH and wet mount KOH for the candidiasis and trichomonas and for those. So treatment is basically obviously lifestyle modification comes first. First thing first, what is that? Hygiene and local measurements, hand washing, and obviously cotton underwear, no nylon tights, no tight fitting clothes, no sleeper pajamas, sits bath, avoid bubbles. So you have to remember this by heart. Every single word. This is very, very important. Urination with the legs spread apart, and you know how you have to counsel about the prevention of it. So this comes here. Then barrier cream, which is basically zinc oxide infection, is basically antibiotics. So on the side is hygiene written, that's we already have read here, so you can remember here. And prepubertal and adolescent gynecological infection legal. So this is basically ethically. A woman is coming to you clinically who treat adolescent must be aware of the federal, state, and the so you have to, like, if a 16-year or 14-year-old girl coming and their parents are asking, you cannot reveal their uh, uh, disease to their parents if they are not willing. If the child doesn't want, like that 16 particularly year old girl doesn't want to reveal it to their parents, so you have to keep the confidentiality. Clinicians must be aware of the guidelines governing funding source of the particular services, and be like, how you give contraceptives, how you, so you need to know what are basically kept confidential and what should be the consent taken from that particular patient before treating them. So now comes these three: pinworm, lichen sclerosis, and foreign body. Lichen sclerosis is important, area of the white patches and thinning of the skin, and topical steroid cream. That pinworm is basically you check on the cellophane tape and you give mebendazole. Foreign body, obviously a woman coming with a foul smelly discharge. So not a woman, but a 13-year or 14-year-old girl. So you have to rule out maybe she had foreign body, or maybe like a 5-year-old girl, she can present with that. So irritation of the vagina with a saline and irrigation. So the irrigation of the vagina with a saline may use local anesthesia on an exam under anesthesia. Then what are the organisms? Candidiasis, bacterial vaginosis, and trichomoniasis. Candidiasis, bacterial vaginosis, and trichomoniasis. So you need to know the pH. pH is basically here, it is written wrong. Candidiasis is more than 4.5. Bacterial and trichomoniasis is less than 4.5. So I don't know why they make this kind of mistake here. But in the old Toronto notes, and maybe in Toronto notes 2023, they might have changed it to this thing. So you need to know which pH is high in which one. So candidiasis becomes in the high pH. That's why the candidiasis organism grow if high pH. In low pH, it cannot grow. So that's why you need to know the pH. Sometimes they mention pH, and then on the basis of that, you need to make the diagnosis. So the risk factors basically immunosuppression in the candidiasis, antibiotics, and estrogen level, pregnancy, OCPs, cotton cheese, minimal, whitish, 20% asymptomatic, pruritus, swollen, inflamed genitals, vulvar burning, and dysuria and dyspareunia. So more than 4.5 and KOH, wet mount, reveal, hyphae, and spores. So treatment is basically clotrimazole, butoconazole, and muconazole. So basically vaginal treatment is given in pregnancy. So you need to know that in pregnancy what are you giving, and in the other woman what you are giving. So in pregnancy you give vaginal treatment. Other is basically prophylaxis like boric acid, vaginal suppositories, and fluconazole, and like in the partners don't need to treat. So then comes is basically bacterial vaginosis, which is caused by Gardnerella vaginalis, Mycoplasma hominis, and Prevotella, which is basically caused by vaginal intercourse and smoking and douching. So it presents as a gray, thin, foul smell. So you need to remember all of this is very important. So they give the presentation of diffuse, thin, fishy, smelly discharge, fishy odor after coitus, and the vaginal irritation. It's more than 4.5. Its pH is more than 4.5. Then more than 20% of the clue cells, squamous epithelial cells, WBC of the paucity of WBC, paucity of the lactobacilli, and fishy odor with the addition of KOH. No treatment in the non-pregnant women. So this is very important. If they can with the non-pregnant woman, so you don't need to treat. But in the pregnant woman, because of that preterm labor here associated with the recurrent preterm labor, that's why you have to give the treatment, and which is given as orally. In the candidiasis, you are giving vaginal treatment. Here you are giving oral treatment, which is basically metronidazole. So in the vaginal is basically metronidazole, clindamycin, probiotics can be given associated with the recurrent preterm labor. So that's why you are treating the pregnant woman. Recurrent preterm labor, preterm birth, postpartum endometritis, and routine treatment of the partners is not treated. Only in the trichomonas you treat the partners. So this is caused by the trichomonas vaginalis, then sexually transmission, yellow green malodorous discharge. This is basically typical presentation of the strawberry cervix. If you go and search on the Google, they show the strawberry cervix. There is a small petaki, and every time you touch or you do the examination or after intercourse, what happens is there is a mild bleeding, sometimes heavy bleeding, but mild bleeding is present. So on the examination, you find the strawberry cervix. So sometimes they say there is a petaki, or sometimes strawberry cervix, or sometimes there is a blood that is coming along with it. So that is basically presentation of trichomonas. Otherwise, in any of the infection, there is no blood. Only trichomonas presents with a little amount of the blood. So petaki on the vagina and cervix occasionally is irritated, tender vulva with dysuria, pregnancy, flagellated, WBC, inflammatory, and have a positive BIF test. Treat with the metronidazole as usual. So pregnant women should be treated with the metronidazole. So you have to treat the sexually partner as well. Then comes the STIs. STIs are very, 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 very high yield topic. I cannot say that you enter in the exam and you don't know STIs. This is like, going somewhere and you are not even well prepared. So STIs are very, very important. You need to know every single word from this onwards. What is basically notifiable diseases? Chancroid, chlamydia, gonorrhea, hepatitis A, B, C, HIV, syphilis. So you need to remember this. Risk factors are basically history of infected, previous infection, maybe you have a contact, maybe patient have a contact with infected and sexually active individuals less than 25, multiple partners, new partner in the last 3 months, and barrier protection is not used like condoms. So social factors. So if somebody is coming with you and using contraceptives, what other counseling you will do? You have to ask to use a barrier method. So on the basis of contraceptive, you cannot say like stop using condoms. You still have to use condoms. So it is very important. You have to tell about the barrier protection method. Then comes the trichomoniasis that we already discussed about it. Then comes the chlamydia. Chlamydia is basically the most common and the most common bacterial STI in Canada. It is caused by Neisseria gonorrhoeae, asymptomatic mucopurulent discharge, dysuria, frequency, pyuria, and no pregnancy on culture. Pelvic pain, bleeding on the intermenstrual bleeding. I will post about this. I have a very good MCQs in my mind right now. I'll post MCQs in the group regarding chlamydia, and I will let you guys to choose the answer. Postcoital bleeding or the intermenstrual bleeding, and then comes a symptomatic sexual partner. Because of a symptomatic sexual partner, you have to treat the partner as well. It's not fully treated if the partner is not treated. If you are giving the medicines to only one person and the partner is not treated, it means you haven't treated that disease fully. So once the patient is treated, you have to treat the partner as well. Then comes the investigation. What you will do: cervical culture or the nucleic acid amplification test, intracellular parasite tissue culture, urine and the vaginal swab now available, so you can use those things. STI testing can be done on the vaginal swab and the cervical swab. Vaginal swab you use for the bacterial vaginosis, trichomonas, and candida. For the cervical, you use test for gonorrhea and chlamydia. Treatment is basically doxycycline. So when you are using doxycycline and you are treating chlamydia, you have to treat gonorrhea as well. So you cannot miss gonorrhea as well. So you have to treat doxycycline and ceftriaxone. I will when I will read gonorrhea, not gonorrhea. Yeah, gonorrhea. Then I will tell you the treatment. Then a reportable disease test and provide the empiric treatment to all the sexual partners of the index case within 60 days prior to the treatment. So you to the symptoms and onset at the date of the specific collection. Test of cure is recommended 3 weeks after the collection of the treatment, with the compliance to treatment is suboptimal and alternative treatment regime is used, or the person is prepubertal or pregnant. So test of cure is not done in every single person. Only the symptomatic one on the pregnant, in prepubertal, or the treatment when she is like you are certain that she didn't take the treatment. only those you have to do the test of cure. What is test of cure? Test of cure is basically when you already did the curement, you already did the treatment. Now you need to do the test to confirm that if the disease is gone or still present in that patient. That is basically test of cure. And there here is written test of cure is done only on those patients like symptomatic, compliance with the treatment, and pregnant. Screening. During pregnancy, you have to screen asymptomatic sexually partners under 25, neonates born to mother with the chlamydia, and any other patient with the risk factors of the sexually transmitted and the bloodborne. And then complications, obviously, PID, pelvic inflammatory disease that comes from the STIs, infertility, ectopic pregnancy, pelvic pain, Fitz-Hugh-Curtis syndrome, reactive arthritis, conjunctivitis, and pneumonia. Then comes the gonorrhea, that is basically Neisseria gonorrhea, symptomatic and the risk factors same as chlamydia. What are the tests that are done? Obviously, the same test to be done, gram stain and the gram negative, cervical, rectal, and the culture if clinically indicated. So most of the time what happens is these gonorrhea is not shown on the culture. That's why you do the NAT. Like when you do the culture, sometimes it comes as negative, like this might be the false negative. So that's why you need to do NAT test to surely rule out that this is not gonorrhea and or either this is gonorrhea. So on the side, and then investigations of the treatment, this is the treatment. So single dose of ceftriaxone plus azithromycin. Why azithromycin? Because you have to treat the chlamydia as well. It's written here. If pregnant, the above regime like ceftriaxone plus azithromycin, avoid quinolone. Also treat chlamydia due to the high risk of co-infection. So if you are treating chlamydia, you have to treat gonorrhea. If you are treating gonorrhea, you have to treat chlamydia. It's just like hard and fast rule. You cannot miss it just from the basis of, oh, it's gonorrhea, so you cannot give chlamydia. You have to treat both together. Then comes the treatment partners like reportable disease screening with the chlamydia. Then HPV is very important. The screening you need to know. We will read in the family medicine. Most common viral STIs, 200, more than 200 types, of which are more than 30 are genital ones, and 6 and 11. I remember the small ones are not oncogenic, but the bigger one like 16, 18, 31, those all are oncogenic. Like oncogenic means causing cancer. HPV is rapidly transmittable between the opposite and same sexes partners through the receptive and the penetrative, like vaginal, anal, oral. So if a female is having having a partner of female, still you have to do the treatment of HPV. If a male is having a partner of male, then still you have to do the treatment or screening for the HPV. It can come because it can come with vaginal, anal, oral, or non-penetrative, like digital vaginal or skin-to-skin contact. So it is a very common scenario that is mostly asked in like in the groups, and they were asking about this kind of stuff. So a highly yield topic, I would say. Infection with the one HPV does not mean that you are safe from other HPVs. So one might come with a different one. So everything is different. Then the latent infection, there is no visible lesions and asymptomatic and only detectable by the DNA hybridization test. Subclinical is basically colposcopy or on the pap test. Clinical infection is basically checked pharynx too, because there might be warts that is present in the oral cavity, so you have to check those ones. Hyperkeratotic, ferocious, and flat macular lesions, valvular edema. All you do is cervical like cytology, pap test. What is done is basically HPV DNA testing or colposcopy or liquid based cytology. So all can be done, but on the basis of what is presenting at what level. So you cannot start from colposcopy right away. So you have to start from the pap test, then comes HPV DNA testing, then comes colposcopy. When you will do the screening, you will get to know about that. Treatment is basically podophylaxis, two type of treatments, either patient administered or provider administered. Patient administered means patient can use it by itself, like having a tube or like a gel, so she can provide it like on her own, which is basically podophylaxis, imiquimod, syncatechins. So these are present. And the patient provider, basically doctor, is applying. What is that? Cryotherapy and podophylaxis, TCA. TCA is safe in pregnancy. Okay, so you need to remember what you can use in pregnancy, which is basically TCA. Cryotherapy with a liquid-based nitrogen is one of the very best method. If I would have to choose, and they ask about which one is the best one, like everything is written in the options. So I will choose with the cryotherapy and liquid-based nitrogen, which is like like one of the very good, like 99% method. Then intraepithelial lesion in the cancer. Then prevention is basically Gardasil and Cervarix. So condoms may not be used. The most common use is Gardasil, and condoms may not be fully protected. So still you have to ask about the barrier method as well. Then comes the HSV. HSV is very painful and maybe sometimes asymptomatic, but when it shows the symptoms, it comes as a tingling, burning, and pruritus. The other STIs doesn't show with the pain, but this shows with the pain, like multiple painful shallow ulcerations and the small ulcers, lesions or infection, lymphadenopathy, malaise, fever, urinary retention, dysuria, much less severe and less frequent. Then investigation is viral culture, HSV, DNA, PCR, Zank smear, and type specific serology test. So what one test you can use is basically HSV, DNA, PCR, or viral culture. The Zank smear is basically low sensitivity, so you can skip it. Not skip it, but you need to know. But it's like it's not very high sensitive, I would say. Treatment is basically acyclovir, valacyclovir. Acyclovir is also used for the recurrent, and daily suppressive is basically more than 6 recurrence. So you can give acyclovir like per oral BID. Then in the severe cases, you have to give IV. Education about the transmission, like avoid sexual intercourse meanwhile until the lesions have been resolved, and use barrier method. Then comes the syphilis. Syphilis you will read in different like topics in family, in infectious diseases. So you need to know, it's like kind of important. Treponema pallidum, primary, secondary, and latent. Primary is basically like after exposure, it presents like painless inguinal lymphadenopathy. Then comes the secondary, which is basically condylomata lata, and then in latent, there is no clinical manifestation. I have seen one of the MCQs in somewhere where they were asking which presentation comes in which level. So primary comes with the chancre, secondary comes with the condylomata lata. So you need to know. Epidemiology of the genital ulcer is HSV and primary syphilis and chancroid. These are basically epidemiology, which one is more common. The HSV is more common. Then is tertiary. Tertiary is basically presents with a different, like involving different systems like neurological and cardiovascular. Then congenital, like fetal anomalies, stillbirths, and neonatal investigation is basically dark field microscopy, treponema and non-treponema pallidum and treponema pallidum. It is very important. You need to know which is used for the diagnosis, and I will leave it to you. You have to Google it and write the answer in the group, which one is the diagnosis one. Okay. Then comes the treatment. Treatment is basically benzathine penicillin for the treatment of primary, secondary, and latent. But in the neurosyphilis, you have to remember, in the primary, secondary, and latent, you give benzathine penicillin. But in neurosyphilis, what you give is aqueous penicillin. It is very important that you don't mix these words. Okay. Then comes the screening, high risk factor groups. So you have to screen in all the high sexual partners and incarceration and in pregnancy as well, in complications and HIV. Complications basically 25 to 30% with the latent infection. And HIV you will read in the infectious diseases. Then comes the PID, which is very important. Up to 20% of all the gynecological infection, hospital admission. So you need to know in PID when to treat in outpatient and when to treat inpatient. So these are two things that you need to know at which level you have to admit the patient. Inflammation of the upper genital tract infection like endometrium, fallopian tube, ovaries, pelvic peritoneum, and contiguous structures that affect young and the sexually active women. PID up to for accounts for 20% of all the gynecological hospital admission. Then chlamydia trachomatis and Neisseria gonorrhoeae and mycoplasma genitalium, E. coli, and mycoplasma tuberculosis. So any organism can cause this, which is presenting in 15 to 25% multiple partners, previous PIDs, and IUD can also occur. Extremely rare, but still it can, present with it. Clinical features, wide spectrum of the features, like maybe time course is different in different women, so it can present in different clinical features. Basically, fever more than 38, low abdominal pain, tenderness, abdominal discharge, nausea, vomiting, dysuria, abnormal uterine bleeding, pelvic pain, dyspareunia, palpable mass, and then very difficult to treat. So what is the investigation you will do? Start with the beta ECG. You have to do ectopic pregnancy, CBC, and blood cultures, routine and microscopy, vaginal swab for the gram stain, culture and sensitivity, nucleic acid amplification test, HIV, and serology testing. Then ultrasound normal may be normal, free fluid in the cul-de-sac, and maybe abscess is present in the ultrasound, hydrosalpinx, and laparoscopy. Treatment is basically laparoscopy, so you rule out if this is failed. Sorry. Okay, so failed one, it's a low sensitivity, and surgery has a high sensitive specificity. Treatment is basically polymicrobial coverage, so you have to give ceftriaxone or either doxycycline or clindamycin. Not clindamycin, actually doxycycline and azithromycin. Percutaneous drainage, when you can find abscess on ultrasound. Otherwise, you don't have to do percutaneous drainage. Laparoscopic drainage, if you find the ultrasound same, self-injectomy and total abdominal hysterectomy and bisalpingo-oophorectomy if the failure of the above treatment. Then IUD, if IUD is present, so you have to remove the IUD in like 24 hours. Reportable disease, treat the partner as well, retesting for the chlamydia trachomatis and Neisseria infection. So this is how it is treated in inpatient and outpatient. This is very important. Indications when to do inpatient and outpatient. Inpatient is very severe illness, atypical infection, abdominal tubo-ovarian abscess, oral therapies failed, immunocompromised, pregnant, adolescent, surgical. If like things are getting out of control, so you have to do inpatient. Antibiotic is basically which one? Cefotaxime and doxycycline, as I already mentioned. Clindamycin and gentamicin, IM or IV. IV antibiotics for the 24-hour improved, then doxycycline can be given. Then outpatients typically finding mild to moderate oral antibiotic compliance in short, follow-up within 48 to 72 hours. First is basically ceftriaxone and doxycycline as gone. So you can start with the per oral and then you can move on to the next one if it's not working, or cefotaxime and probenecate or doxycycline, whatever you can remember. Then complications like pain, hydrosalpingo peritonitis, adhesions, ectopic pregnancy, infertility, bacteremia, arthritis, and endocarditis. So that's what I'm going to cover from gynae. So menopause, you can read menopause is just like the contraceptives. This is the treatment you need to remember from. For the treatment is very important. So in the vasomotor, the first line is menopausal hormonal therapy, which is basically like all the contraceptives. Then SSRI, venlafaxine, gabapentin, propranolol, clonidine, acupuncture, behavioral modifications, atrophy. You start with a local estrogen cream. If that fails, then you go for vaginal suppository. If that fails, then go for ring, lubricants. Vaginal health is basically, urogenital health is basically lifestyle system like bladder, weight loss, pelvic floor exercises, local estrogen therapy. Osteoporosis, give with calcium and vitamin. If that fails, then bisphosphonates. So if that fails, then HRT. So libido is vaginal lubrication and counseling, androgen replacement therapy, testosterone cream for the libido. Then basically CVD for the, you have to manage CVD according to risk factors. Mood and memory then gives antidepressant, which comes as a first line. On the side, 85% of women experience hot flashes, 20-30% seek medical attention, and 10% are unable to work. So that's about it. And the contraceptive, just like the contraceptive, you have to remember the benefits and the risks. It is very important. And the components. So this is something you can remember. When to use when and what to use when. So if there is no contraindication, you can start with the oral contraceptives. If there is contraindication, then you can start with SSRIs. If there is a contraindication, then you can start for the lubricants and moisturizers if that is having vaginal dryness. If not, then you can switch into like avoid HT, right? And if the woman is having no like prior hysterectomy, what you can use estrogen only options. But if she hasn't done hysterectomy, then you have to use both. So I guess that's enough for the gynae. Let's stop the recording.